position of professor in 2015. Professor Onyiruka was sponsored by the World Diabetic Foundation for the Award of Fellowship of the European Society for Paediatrics and Endocrinology, FESPE, in 2014, and was awarded a certificate in pediatric nutrition from Boston University Medical School, United States of America, in 2022. Professor Onyiruka has held several administrative positions within the university, such as coordinator, undergraduate studies, Department of Child Health, School of Medicine, 2004 to 2006, postgraduate training in Pediatrics, University of Benin Teaching Hospital, 2006 to 2009, Comprehensive Health Center, Udo, University of Benin Teaching Hospital, from 2009 to 2016, and also Departmental Representative, Ethics and Research Committee, University of Benin Teaching Hospital, from 2015 to date. He was also the head of Department of Child Health, University of Benin Teaching Hospital, from 2018 to 2022. Professor Onyiruka belongs to several professional bodies and associations such as member, Nigerian Medical Association, member, Pediatric Association of Nigeria, member, Medical and Dental Consultant Association of Nigeria, member, International Society for Pediatric and Adolescent Endocrinology, and Society of Pediatrics and Adult Endocrinology in Nigeria. He has served as external examiner and assessor to several universities within and outside the country. He is also an examiner in pediatrics for the National Postgraduate Medical College of Nigeria. He has over 50 publications in local, national, and international journals. He has also published a monograph titled Failure to Thrive, and he is an editorial board member of many academic journals. He has also successfully supervised over 8 dissertations for the fellow of both the National and West African Postgraduate Medical Colleges. He is happily married and blessed with children. Distinguished ladies and gentlemen, it is my pleasure to invite Professor NDIDIAMAKA ALPHONSUS ONYIRUKA to deliver his lecture.
Permit me, Madam Vice Chancellor, to stand on existing protocol as established by the PRO of this distinguished university to deliver the 298th inaugural lecture of this university and the 7th in my department. This inaugural lecture is dedicated to Almighty God, who is the owner of everything, visible and invisible, for His grace and mercies upon my life. It is also dedicated to my numerous patients and their parents who willingly participated in my research endeavors over the years. This is the outline of today's lecture. Madam Vice Chancellor, I sincerely thank the Almighty God, my Creator, for making it possible for me to address this August assembly of this 29th series of the inaugural lecture of this distinguished university and the 7th in my department. Standing on this podium to present this lecture today, the 25th day of January 2024, is an accomplished vision that no one in my lineage would ever have dreamed of nor imagined, but for the grace and the benevolence of Almighty God. I was appointed a lecturer working in the Department of Child Health in 1999, but my appointment as an honorary consultant in UBTH, which traditionally should have been automatic, was delayed for 6 years. I am very grateful to Professor Endocrine Ogbene, the then Chief Medical Director of UBTH, who eventually appointed me as an honorary consultant in UBTH. The importance of this appointment is that it created a platform for research, which is the basis of today's inaugural lecture. My standing here today as a certified pediatric endocrinologist, the first and the only one in Edo State, was made possible by the opportunity given to me by the former UBTH Chief Medical Director, Professor M.O. Ibadin of blessed memory, and the former UNIBEN Vice Chancellor, Professor F.F.O. Uruwense, to go for the relevant training. I salute both of them. Basically, endocrine disorders are due to treatment reasons: excess production of hormone, inadequate production of hormone, or problem with the receptor. So, since hormones play a vital role in endocrine disorders, so hormones themselves are chemical messengers secreted by glands, organs, and tissues, and they control different functions in the body. The term hormone is derived from a Greek phrase meaning to set in motion, which describes the function of hormones. There are three classes of hormones: the peptide hormones, the steroid hormones, and the immune hormones. The peptide hormones are mainly those secreted by the hypothalamus, the pituitary, and of course including insulin. Steroid hormones are cortisol, the sex steroids, and then vitamin D. While the immune hormones include adrenaline and the thyroid hormones. The endocrine system. The endocrine system consists of glands, cells, and tissues that secrete hormones. And these tissues include the skin, adipose tissue, gastrointestinal tract, and the kidney. And these form the diffuse endocrine system. The major endocrine glands are spread all over the body. In the head, we have the hypothalamus, the pituitary, and also the pineal gland. In the neck is the thyroid gland, the thymus, and the parathyroid. And in the abdomen, the adrenal glands, the pancreas, and then in the gonads, the ovaries and testes. The embryonic origin of endocrine system is from the three germ layers of embryo: ectoderm, mesoderm, and endoderm. The ectoderm, the pituitary gland, and the adrenal medulla arises from the ectoderm, whereas the adrenal cortex and gonads arise from the mesoderm, and the endoderm use thyroid gland and parathyroid as well as pancreas. The key functions of the endocrine system is to regulate the metabolic functions of the body, regulate the rate of chemical reactions in the cell, and also to influence the ability of substances to transport themselves across cell membranes. What is pediatric endocrinology? So pediatric endocrinology is a subspecialty in pediatrics that studies hormones and their actions, the glands that produce them, and related disorders in childhood. From the title of this lecture, it includes the body. Therefore, let's say a few words regarding the burden of a disease. The burden of a disease is the impact of a health problem on a given population, and there are various indicators of this burden, which includes mortality, morbidity, and financial cost. Other indicators include quality adjusted life years and disability adjusted life years. Why is it important to measure disease burden? Because it helps in prioritizing action, in health and environment, in preventive measures, and in assessing the healthcare systems, and also identify populations at risk, and also help in planning future needs, and of course in setting priorities for health research. So the body of pediatric endocrinology in Nigeria, we determined the prevalence of pediatric endocrinology disorder, and we found that 0.7% of all children seen in UB to age over a period of 10 years had endocrine disorders. And diabetes mellitus was the most common, accounting for 17.8% of them all. Other leading endocrine disorders include disorders of cell development, thyroid gland, and energy balance. This was reported by ONYIRUKA and Paediatrics in 2014 in the Nigerian Journal of Paediatrics. So because diabetes mellitus is the commonest among the endocrine disorders, so we'll talk a bit about diabetes mellitus. Diabetes mellitus is a complex metabolic disorder characterized by chronic hyperglycemia resulting from defects in insulin secretion, insulin action, or both of them. Diabetes mellitus is not a single disease but a heterogeneous group consisting of type 1, type 2, other specific types, and gestational diabetes. Gestational diabetes occurs in pregnant women. Now, the other specific types, in the society, people believe that diabetes mellitus occurs only in adults or in the elderly. But from this table, you can find that there is neonatal diabetes mellitus. Neonatal mellitus can occur anytime from birth till the age of 6 months. So any diabetes occurring during that period is regarded as neonatal diabetes. Even the drugs that we take, glucocorticoids for example, and L-asparagines, they also lead to diabetes mellitus. In fact, by ONYIRUKA et al. In 2012 in Tropical Journal of Medicine and Biomedical Research. We went on to look at the pattern of presentation of childhood diabetes mellitus, and we found that 3/4 of them presented in ketoacidosis at the time of first diagnosis. In developed countries, these figures are less than 25%, but here, up to 77.1% presented with acute complication of diabetes mellitus. And many of these people that have DKA also require readmission because of wrong advice from pastors, native doctors, spiritualists who claim that the patient has been cured. This was reported by ONYIRUKA in 2013 in the International Journal of Endocrinology and Metabolism. We also went ahead to look at the frequency and family history of children with type 1 diabetes mellitus as part of the body of endocrine disorders. And we found that 4 out of every 10 had a positive family history, and most of them were first-degree relatives. And first-degree relatives here means parents and siblings. Many of them have multiple members of their family who also had diabetes mellitus. And the higher the number of members of that have diabetes mellitus, the greater the chances that the child will develop diabetes mellitus. Majority of these family members had type 1 diabetes mellitus. This was published, this was reported by ONYIRUKA et al. In 2018 in the Malaysian Journal of Paediatrics and Child Health. There is familial clustering of diabetes, and here we report a case of a 9-year-old boy with type 1 diabetes mellitus whose 3 elder sisters also had impaired fasting blood glucose, which defines pre-diabetes. This was published by ONYIRUKA in 2015 in Aristotle University Medical Journal. So pre-diabetes is an alert that diabetes will soon develop later. because the cells of the body gradually resistant to insulin, although pancreatic production of insulin was adequate. As part of the burden of endocrine disorders, we looked at the psychosocial impact of diabetes in adolescents, and we found that we examined the parental support, and we find that in only 1/3 of them reported that they had good parental support, and 16% of them said parental support was poor. Majority of them stated that their quality of life has dropped since they no longer enjoy the things they used to enjoy before the diagnosis. And 15.8% and 9.7% respectively had delayed menarche and short stature. This was reported on ONYIRUKA and in 2013 in Journal of Community Medicine and Primary Health Care. We went ahead to look at the eating behavior of adolescents with diabetes mellitus, and we found that their meals consisted mainly boiled cocoyam, boiled unripe plantain, and beans. These were the 3 leading food items consumed by adolescents with diabetes mellitus. Of note, over half of them skipped breakfast, resulting in omission of insulin. This is the most unhealthy eating behavior exhibited by adolescents with diabetes mellitus. What is the reason for skipping this breakfast? Either that they do not have appetite, or there is no time in the morning, or that they dislike the available food item at home, or they are angry with their parents. This demonstrates the impact of family food insecurity and psychosocial issues in diabetes mellitus. This was reported by ONYIRUKA et al. In Sri Lanka Journal of Diabetes, Endocrinology and Metabolism in 2014. Diabetes mellitus is a chronic disease and may also coexist with other chronic diseases. Here we report in separate 2 reports. We describe coexistence of type 1 diabetes mellitus in a child with sickle cell anemia, and that we reported in 2014 in British Journal of Medicine and Medical Research. In 2021, we also reported, ONYIRUKA et al. Also reported a child who has diabetes mellitus, also with glucose-6-phosphate dehydrogenase deficiency. And this was reported, or this was published in Romanian Journal of Diabetes, Nutrition and Metabolism. In 2015, ONYIRUKA et al. Also described a case of a 14-year-old boy with nephrotic syndrome who developed steroid-induced diabetes ketoacidosis following steroid therapy. So showing that children who are on steroids can also develop diabetes mellitus. This was reported by ONYIRUKA et al. in 2015 and published in Nigerian Journal of Paediatrics. When we make a diagnosis of diabetes mellitus, the first statement that the mother will make, God forbid, I reject it, not my child, because they believe, because of the problems associated with management of diabetes mellitus. But we that diagnosis of diabetes mellitus is not an end to the road, because the child can achieve what he is destined to achieve. So usually we show them this picture of a lady who won a beauty pageant in USA, and despite the fact that he has diabetes mellitus. So this is encouraging to the parents so that they pay attention to their children who have diabetes mellitus. Many metabolic diseases occur in children admitted into hospital for one reason or the other. And so we looked at the occurrence of hypoglycemia in hospitalized children, and we found a prevalence of 18.3% in children admitted for malaria And in that study, we also found that risk factors were age, less than 36 months, and last meal greater than 12 hours. This was reported by ONYIRUKA et al. In 2012 in the Nigerian Journal of Paediatrics. In a separate study, we also found that the prevalence of hypoglycemia in children admitted for diarrhea was 7.7%. And the risk factors in that study were severe dehydration, hypernatremia, and acidosis. This was reported by ONYIRUKA et al. In 2012, also published in Nigerian Journal of Paediatrics. Hypoglycemia we also studied hypoglycemia in other diseases. This time, cholestasis of infancy. Study that 1.4% of children who were admitted had cholestasis of infancy, and in them, 22.5% of them had hypoglycemia, and more than a quarter of them had hypoglycemia that was diagnosed in the first 36 hours of admission. Hypoglycemia was severe in 1/3 of cases, and all this was reported by ONYIRUKA et al. In 2013 and published in Oman Medical Journal. We went ahead to look at disorders of the thyroid gland. We assessed the burden of thyroid gland disorders by examining 8,350 patients seen in the Department of Child Health over a period of time. And 0.11% had thyroid disorder, and 2/3 of them had hyperthyroidism. This was reported by ONYIRUKA et al. In 2012 in Pacific Journal of Medical Sciences. Some systemic diseases sometimes will manifest with skin problems. And here, to illustrate the burden of endocrine disorders, we reported this case because this shows that although this patient had Graves' disease, it's a 16-year-old girl who has Graves' disease, but also in the toes is this loosening of the nails bed. And so when we find a patient that has such feature, then we may also look out for hyperthyroidism. Or if we find a patient with hyperthyroidism, we can also look out for such oligolysis. Here we reported the case of a 7-month-old child who had resistance of thyroid hormone to the pituitary. Because the pituitary does not respond to thyroid hormone, then the negative feedback on pituitary is lost. Therefore, there was high levels of TSH, which resulted in goiter in this patient. As we can see, this is goiter in the neck of this patient as an enlarged thyroid gland, and the ribs in this patient are prominent because the patient has failure to thrive. His birth weight was 2 kilograms, but at the time he presented, at the age of 26 days, his weight was 1.6. And so we increased his caloric intake, and his weight moved up to 4.4. But we have since lost this patient to follow. So we also studied disorders of energy balance. Using the criteria for WHO and using BMI, we found that the prevalence of underweight, overweight and obesity were 7.1, 8.3% and 2.1% respectively. The prevalence of underweight and overweight in this study were similar, demonstrating the double burden of nutrition among adolescent girls in Nigeria. This was reported by ONYIRUKA et al. In 2015 in International Journal of Child and Adolescent Health. We studied the eating habit because of the problem of obesity. We also studied the eating habits of adolescent school girls, and we found that 48% of them skipped one main meal every fortnight, and the meal that is often skipped is breakfast, despite the fact that breakfast is the most important of the 3 main meals. 3/4 of these participants consumed fast food with sweetened beverages, and 15% of them ate fruits and vegetables daily. So this was reported by ONYIRUKA et al. In 2013 in Sri Lanka Journal of Child Health. We went ahead to look at the gender differences in children with overweight and obesity in adolescents in the local government area. In that study, we found that there was a higher prevalence of overweight and obesity in pre-pubertal than pre-pubertal girls, with the opposite found in boys. This was reported by NDIDIAMAKA, ONYIRUKA, Sado et al. In 2022 and was published in Borno Medical Journal. In a separate study, we found that overweight and obesity was more common in girls than boys, and that the females themselves were older, heavier, and consumed fast food more frequently than the males. This was reported by NDIDIAMAKA, Abiodun, Sado, and ONYIRUKA in 2023 and published in West African Journal of Medicine. We know that overweight and obesity is associated with physical activity and also hypertension. Therefore, we studied children, primary school children aged 5 to 12 years. In them, we found that only 1/3 of them met the recommended level of physical activity. And the prevalence of hypertension was found to be 4 times higher in overweight obese children compared to their healthy weight counterparts. The prevalence of hypertension was 6.5 in overweight pupils as compared to 1.5 in healthy weight counterparts. This was reported by Sado ONYIRUKA in 2016 in African Health and published in African Health Sciences. We studied the disorders of lipids, and we found a high prevalence of dyslipidemia in both overweight and normal weight Nigerian adolescents. And the frequency of dyslipidemia was higher in girls compared to boys. And the commonest dyslipidemia found in them was low level of high density lipoprotein. And this was reported by ONYIRUKA et al. In 2021 and published in Sri Lanka Journal of Diabetes, Endocrinology, and Metabolism. Of the serum lipid levels, we looked at the triglyceride and high density lipoprotein cholesterol ratio, and we found that the mean triglyceride and HDL ratio was higher in overweight people compared to their counterparts who have normal weight. And in those studies, that 8.8% of them had triglyceride high density lipoprotein cholesterol ratio that is in the upper third. We also found that triglyceride over high density lipoprotein cholesterol ratio greater than 2.275 was associated with insulin resistance. We therefore recommended that when we do lipid profile of patients, we should calculate the triglyceride over high density lipoprotein ratio, as this can give us a clue to the presence of insulin resistance in this patient. This was reported by ONYIRUKA et al. In 2019 and published in Romanian Journal of Diabetes, Nutrition, and Metabolism. What we eat can influence our serum lipid level. We described a case of a 22-month-old child with type 1 diabetes mellitus who developed this epidemic following daily consumption of fried chicken eggs over a period of 4 months. Therefore, as we eat fried chicken eggs, we should be careful so that this do not lead us to this epidemic. And his total cholesterol level at the age of 22 months, less than 2 years, was 223 milligrams per year. A high-density lipoprotein cholesterol was 103 milligrams per year, and other serum lipids were borderline high. However, after we have normalized, they normalized after adjusting the child's dietary practice. This was reported by ONYIRUKA et al. In 2018 and published in Malaysia Journal of Paediatrics and Child Health. We examined the abnormalities of external genitalia, and we found that the prevalence of abnormal external genitalia was 2.1%. The 2 females that were present also had ambiguous genitalia, had congenital adrenal hyperplasia, suggesting that congenital adrenal hyperplasia is probably the commonest cause of ambiguous genitalia in children. In males, the frequencies of undescended testes and hypospadias was 2.4% and 1.3% respectively. The undescended testis was more frequent on the right than the left, and low birth weight babies had a significant risk factor. This was reported by ONYIRUKA et al. In 2016 in International Journal of Child and Adolescent Health. We went ahead to look at the endogenital distance in Nigerian newborn. Refers fetal exposure to androgens, and we've determined that the normative value for endogenital distance was 28.3% in males and 15.2 millimeters in females, with a ratio of 1.7. Thus, we contributed to knowledge by filling existing gap in clinical practice, because in Nigeria there is no normative value for endogenital distance. This was published by ONYIRUKA and Endocrine in 2016 in Journal of Paediatrics. So this diagram tries to illustrate to us what we mean by endogenital distance. For the males, from the anus to the scrotum is endogenital distance. From females, from the anus to the foetus is the endogenital distance. We also found that endogenital distance was shorter in males who had hypospadias compared to those that have undescended testes, suggesting that in hypospadias there were more severe androgen deficiency in fetal life. This was reported by ONYIRUKA and NDIDIAMAKA in 2018 and published in Orient Medical Journal. Endocrine disorders is not only the child, that mothers that have endocrine disorders, it has an impact on their offspring, illustrating the high burden of endocrine disorder in children. In this regard, we reported a case of an infant, born to a mother with gestational diabetes mellitus, who was found to suffer hypocalcemia, hypoglycemia, macrosomia, and undescended testes in the first few days of life. This was reported by ONYIRUKA et al. This was reported by ONYIRUKA and Endocrine in 2016 and was published in Romanian Journal of Diabetes, Nutrition, and Metabolism. We also studied mothers who are obese and compared them with mothers who are not obese, and we found that the risk of delivery of microsomic babies was much higher in mothers who are obese compared to those who are not obese, at least a 5-fold increase. And so this again was reported by Endocrine and ONYIRUKA in 2016 2017 and was reported in International Journal of Child and Adolescent Health. The treatment that we doctors give to patients sometimes create endocrine disorders. Here we describe the case of iatrogenic Cushing syndrome in 2 boys aged 19 and 9 months respectively who developed Cushing syndrome following use of intranasal steroid over a period of 2 to 3 months for adrenal hypertrophy. Therefore, as we prescribe steroids for patients, we should not look the other way. We should pay attention and make sure that we are not creating further problems with them. And in these patients, the dosages were high and the duration of administration was prolonged. This was reported by Oluwayemi, Oduwole, Oyirisi, ONYIRUKA, etc. in 2014 and was published in Pan-African Medical Journal. Now the challenges. The challenges of any health condition includes increasing prevalence, economic impact, shortage of healthcare providers, and the risk of impaired health-related quality of life. All these are frequently seen in chronic diseases, of which endocrine disorders are a good example. Endocrine disorders are, par excellence, chronic clinical conditions. So the challenges include inadequate number of pediatric endocrinologists, lack of other trained manpower, inadequate medical laboratory facilities, and family financial constraints. With regard to inadequate number of trained pediatric endocrinologists, pediatric endocrinology is a relatively young area in pediatrics because in fact, started about 25 years ago in Nigeria following the graduation of a fellow from Canada. And this fellow is Professor Oduwole, who is also my mentor. And she was the only pediatric endocrinologist for over 15 years. And as I said previously, currently I'm the first and only certified pediatric endocrinologist in Nigeria, in Edo State. Therefore, we need more pediatric endocrinology. So, people in pediatrics should endeavor to study pediatric endocrinology. When there are current efforts in order to increase the number of pediatric endocrinologists, the European Society for Pediatric Endocrinology, International Diabetes Foundation, and International Society for Pediatric and Adolescent Diabetes established 2 training schools, one in Kenya and the other one in Nigeria, to train pediatric endocrinologists. So far, 37 fellows have been trained in pediatric endocrinology who are working in Nigeria, but they are not evenly distributed. 13 of them is in the north and 24 of them in the south. Endocrine disorders require a team management. Therefore, we need other trained manpower like nurses, dietitians, diabetes educators, and psychologists in order to provide optimal care. So in this regard, a few years ago, I nominated a nurse and a dietitian from UPTH, and we attended a training program in Ibadan for free. They are still working in UPTH today. So inadequate medical laboratory facilities is also another challenge. And this is a huge challenge because lack of it impairs diagnosis and follow-up of pediatric patients with endocrine disorders. Because standard laboratories for hormonal assays is grossly lacking, and the laboratory results often obtained from laboratories in town are often difficult to interpret, limiting their usefulness. The fairly good labs charge exorbitant prices, which parents sometimes are unable to pay for. We studied the financial constraint to illustrate the impact of diabetes mellitus on finances of families. And in that study, we found that 50% of the participants had to pay $60,000 to $69,000 for care. And this was published by ONYIRUKA in 2012 in Institute Journal of Medicine. The resultant effect is that these parents are unable to pay for diagnostic investigations and also unable to procure insulin on a regular basis and inability to acquire glucometer for test strips. This pie chart shows us illustrates what I've just said. So we see that 50% of them spend this large amounts of money to care for their children. Here in this pie chart, we studied the source of the ability of parents to pay for diabetes care. And we found that only about 80% of those people studied had very difficulties in paying for diabetes care out of pocket. The major sources of money we also studied the various sources of money used for paying for direct costs of diabetes, and we found that these parents, many of them, either that they obtain loans or they take money from their capital or they borrow the money. All these activities in order to raise funds makes those families poorer and poorer. And this was published in that previous study that I quoted earlier on. Other challenges in the management of childhood diabetes mellitus include high cost of insulin, glucometer and test strips. Nutritional management is a big problem because the child's eating habit is erratic. Therefore, sometimes it's difficult to control what the child eats. And so sometimes he may eat excessively, sometimes inadequately, and if you administer insulin, you may find that it may cause hypoglycemia or that the insulin you are given is not enough because the amount of calories it's consuming is by far more than the insulin dose that was prescribed. There is also poor access to healthcare services and then because of lack of money. So inadequate manpower, so it will be necessary for postgraduate colleges of Nigeria and West Africa to mount training for membership fellows for a minimum of 12 months and be satisfied. And currently I'm drafting the training curriculum for submission for approval by the National Postgraduate Medical College of Nigeria. So we need to maintain standard, and in order to maintain standard, it might be necessary during renewal of practicing license for part of the requirement to be a refill course in pediatric endocrinology, and that can be supervised by the Pediatric Endocrinology Training Center for West Africa for recertification. So irregular availability of medications, financial empowerment of families to enable them to procure regularly medications and pay for medical investigations. Government should subsidize cost of drugs and consumables required for care of children with endocrine disorders. To access health insurance schemes need to be improved on. Currently, we have the National Health Insurance Scheme, but we should include the non-formal sector. The community health-based insurance scheme is also other ways, and targeted public health insurance is another. Essential drug list should include hydrocortisone. So we need tools to work with. So the pediatric endocrinologists in the 6 geopolitical zones should collaborate to produce comprehensive brochure for Nigerian children. Availability of such brochure will be useful for diagnosis of stature disorders and growth monitoring. According to Michael Faraday, the secret of success is to work, finish and publish. Therefore, establishment as President of Nigerian Journal of Pediatric Endocrinology and Metabolism will provide a platform for Nigerian content in terms of knowledge. Such journal should regularly publish clinical practice guidelines that are tailored to the level of development of healthcare in Nigeria. Recommendations. The postgraduate medical college and West African program can mount 12-month training for membership fellows. Establishment of specialized medical laboratory facilities in each of the sector political zones of the country, public-private partnership should be encouraged, and production of growth charts by the American technologies is also another way. Provision of free insulin and diabetes care consumables will be helpful, and money can be sourced by some GSM tax from a few kobo on every minute of call, and this can be put together and used for them. So the provision of protocol for examination of external genitalia and birth to be used by midwives, physicians and traditional birth assistants, as well as improvement on referral system is also a way. Government should set up newborn screening for congenital hypothyroidism and ensure early diagnosis and prevention of intellectual disability. The recognition of pediatric endocrine and metabolic diseases are part of the spectrum of non-communicable diseases at national, state and local government will be useful. In conclusion, Madam Vice Chancellor, I have through my research and observation provided some insight into the burden, challenges and way forward in pediatric endocrine disorders. It is on this note, my Vice Chancellor and distinguished audience, that I plead to rest my case.
Of the lecture, Madam Vice Chancellor.
Distinguished ladies and gentlemen, I am sure our lecturer, maybe he became too conscious of the fact that he didn't acknowledge all of you seated here. On his behalf, I acknowledge all of you. And I thank the dear wife for putting up with our professor. And I don't know when we had time to sweetie darling you because he was working all the time. But anyway, thank you for standing behind him. And for his dear colleague, medical personnel from our provost. Very soon, we won't be attending your inaugural lectures because it appears when you are giving, everyone appears from BBCH. And then when others are giving, you only attend for your friends. Doctors, professors, we are watching you closely. Please take my message to your people. Okay. Thank you very much. I am sure we are all well educated. The lecturer delivered and delivered. I think we need to applaud him again. So I'm just going to give you a small summary, very short one. So he had said to us that in Nigeria, although the burden of pediatrics and endocrine diseases, are quite high, but that these diseases are just a few that are known to us because often they are overlooked and unrecognized. Such is the very last, it is placed on the last in the pedestal of what our medical concerns are. He has also said that one of the major key barriers that we have in identifying or dealing with children with endocrine diseases, especially diabetes, is the fact that we lack skilled personnel, financial constraints, especially amongst families who are already overburdened by other challenges, difficulty in accessing investigative facilities, and consequently, the lack of affirmation of diagnosis treatment. Other challenges, he said, include the low level of awareness, the myth and fallacies, poor routine newborn examination and documentation, particularly with regard to the external genitalia. These key requirements for proper practice of pediatric endocrinology are grossly deficient in Nigeria, and so pose a huge challenge in clinical practice. Therefore, he has recommended, amongst others, the establishment of one specialized medical laboratory facilities in each of the 6 geopolitical zones of the country and encourage public-private partnership. He has also encouraged that pediatric endocrinologists in the 6 geopolitical zones should collaborate to produce a comprehensive growth chart for Nigerian children, and that government should set up newborn screening for congenital hypothyroidism to ensure early diagnosis and appropriate treatment to prevent intellectual disability that may follow delayed diagnosis and treatment. And finally, the provision of standard guidelines and protocol on examination of external genitalia at birth for the use by midwives, physicians, traditional birth attendants, as well as improvement of referral system. Distinguished ladies and gentlemen, thank you for coming.
Thank you very much, Madam Vice Chancellor, making us all proud. May I now invite the First Lady of the lecturer and the children to come up stage as the Vice Chancellor decorates the lecturer. Please come up stage. Mrs. ONYIRUKA, please put your hands together. Children, two other immediate family members, please join. Join, please. And while we are doing that, we'd like to welcome very specially Mrs. ONYIRUKA, the wife. Madam, yes, please go confidently, yes. ONYIRUKA, son, they may not be here, they are with us joining on Zoom, yes. So Rita ONYIRUKA, daughter, Chinedu ONYIRUKA, son, Ekene ONYIRUKA, son, Ijoma ONYIRUKA, daughter. We also welcome very specially Professor Patrick Uwadia, welcome sir. Welcome Professor Gideon Emelwe. We welcome Professor Ebohan. We welcome Mrs. Maureen Ebomoyi. Welcome also Mrs. Modina Kadiri, who joins together for Professor Mrs. Eruke Baden. Welcome Professor Stanley Okubo, CMAC UBTH. Welcome Dr. Udoko, Eki Udoko, DCMAC UBTH. Welcome Professor Amina Obaku, DCMAC Clinicals UBTH. Now we see what Madam Vice Chancellor was talking about. Please put your hands together for them. Welcome Professor Musakae Idwa Ibikemen. Welcome Professor Enosa Lasse. Welcome Professor Charles Maringiaye. Welcome Professor Molade Awodu. We welcome Professor Sylvia Ogoana. Madam Vice Chancellor, Principal Officers, distinguished ladies and gentlemen, that's how we conclude the 298th in the inaugural lecture series of the University of Benin. Please put your hands together for the University of Benin as we now request all of us to rise. First, the Uniband anthem, followed by the second stanza of the national anthem. Please stop service. After the anthem, we will continue. Stop service, please. you very much, Professor Endosoma.
Bodyguard. I don't know.